Good morning this morning, everyone. Welcome to August 20th, 2021 Buckeye Scope. Let's see, do we have anyone on by phone, Jesse or Andrea? It's hard for me to see. No, okay, nobody on by phone, great. We are in our sixth session, so you should know that the folks with Buckeye Scope and the Echo logos are your hub team members. And we are so blessed and thankful that so many faces have continued to show up week after week. So we've gotten to know you so well in our small groups and large group breakouts. And I heard 2 weeks ago when I was not able to be here, it was probably the best session yet. So shout out to Twinkle if you're on yet this morning. But here's a list. And then today we're going to have our expert presenter as Dr. Adrienne Fricker-Elhai. And she's going to talk about intergenerational trauma and infant mental health. And you can see the schedule upcoming for our remaining sessions 7 through 10. And so today we are going to go through our didactic this morning and then have our clarifying questions, as well as then going into a case that we have. So thanks to Michelle for that. As always, we have captioning, and that would be found at the bottom of your screen to choose for a live transcript. And finally, we will just jump into it. So I am excited to introduce Dr. Adrienne Elhai, who completed her BA in psychology at the University of Missouri, St. Louis in 1994, and clinical psychology at the University of Arkansas in 1998 for her master's and PhD at the University of Arkansas in 2000. She completed an internship in 2 years of an NIMH-funded postdoctoral research fellowship at the Medical University of South Carolina's National Crime Victims Research and Treatment Center. She focused on the research and treatment of children who experienced abuse and trauma. And prior to joining the Cullen Center, Dr. Elhai worked in Sioux Falls, South Dakota at Avera Behavioral Health and the University of South Dakota Medical School's Department of Psychiatry. She's worked with children with a variety of behavioral and emotional problems seen in outpatient, inpatient, and residential settings, and has trained future child psychologists in child therapy. Dr. Elhai has authored 11 peer-reviewed articles, 6 book chapters, and over 30 professional presentations at conferences nationally, has been invited to speak and present at over 70 workshops and media events. And so we could go on, but we are so thankful that you're here, Dr. Elhai. And oh, good, look at those lovely slides. So we will turn it over to you.
Yes, thank you so much. I'm happy to be here. It's hard to hear your life spoken about in front of a group of people, but I really am. I'm so glad that Michelle Rowley reached out to me and that we got to reconnect after we were together at the Cullen Center. Okay, so anyway, so we're talking about intergenerational trauma today. I'm going to go to the next slide would be great. We're going to start with meeting Katie. A little girl. We're going to stop at that right there. And Katie is a little baby that I actually met when she was 3 years old. But I always remember a story that Mom told me about when she was just an infant. And so to know a little bit about Katie, I want to talk about Katie and her mom, Jenny. So Jenny, had a lot of trauma in her life. She grew up in a house with a lot of domestic violence and sexual, physical, emotional. Both of her parents had a lot of violence in their childhoods growing up. Her parents were very neglectful, really, of her, very cold. And so when Jenny was a teenager, she obviously, was looking for connections, and she met Katie's father, and very quickly they got involved, but it was a very violent relationship. And before Katie was born, Jenny actually had 2 other children, and they were together, and there was a lot of violence. I mean, just extreme violence. And by the time that she was pregnant with Katie, they actually were estranged. And so after Katie was born, when she was discharged from the hospital, she brought Katie and her two other children, who were probably about 7 and 5 at the time, to a hotel because she didn't have a place to go. And I remember Jenny telling me really that she was very depressed at the time, and felt very detached from her kids. And she didn't really want to be around them, but not because she didn't care or love them, but because she felt very stigmatized. She felt like, she had just like letters written all over her that there was something wrong with her. And she did not want to give that off to the children. And she felt the children would be better off if she didn't really have much involvement with them. So I have this picture in my mind of when she came home, actually back to the hotel with Katie, that she left them in the hotel, which is what she did. And she left Katie there in the car seat. And so Katie, was crying in the car seat, as infants would do, wanting to get her needs met. But there was no adult there to come and take care of her, only maybe her siblings. And so Jenny did get back together with her husband. And the pattern kind of continued where Jenny was very, very depressed. And she often, she got all of Katie's basic needs met, but often Katie was left, to not a lot of contact, at least with mom, with Jenny. And so when I met her, if you could go to the next, click again, what happened? There we go. Okay, go back. I met Katie, she was 3 years old. Mom had left dad, and she'd been away, had finally been able to leave dad, had been away for about a year. And Katie she had gotten the older kids into therapy, and now was getting Katie into therapy. She only could speak 1 or 2 word sentences, knew about 15 words at that time, and she was actually almost 4. So there was only there was a lot of effects that way. And we'll actually talk more about the effects on Katie throughout her life. So if we go to the next slide, let's talk about what is the definition of intergenerational transmission of trauma. So, I mean, it is what it sounds like, right? It's that transmission of trauma, or that effect of trauma from one generation to the next. And often it's passed covertly. It's not something that is, it's silently, it's not, spoken. And oftentimes when researchers, or when we think about intergenerational transmission of trauma, or intergenerational trauma, I should say, we think about the Holocaust, or Native American tribes, or slavery, and we think about those types of trauma. And actually, that's what a lot of the research has been done on. It's one generation has experienced a huge trauma, and a lot of atrocities, and not the next generations haven't actually experienced that particular trauma, but the effects, they keep going on. And it's through these messaging, through these rules of life that the previous generations have learned, and they passed on, usually not consciously, to the next generations. So obviously, in Katie's case, that's not really what we're talking about. And so intergenerational trauma can also be through more ACEs. So domestic violence, sexual assault, that can also be that cycle. And sometimes this trauma is also passed on, these mental health effects, and these views on life, and the way in relationships, and post-traumatic stress type symptoms that are passed on from one generation to the next. Next slide. So what is this transmission of trauma? How does it pass on? And I'm not going to spend a lot of time on here, but I do think that it's important to kind of think about the transmission. And I kind of talked a little bit about this with Jenny. She thought, she was there was some sort of stigma on her. Like, I think about like the letter A, right? She thought there was something wrong with her. And so that changed the way she interacted with her baby. So here we see that's that interpersonal transmission, means of transmission. So how is the one generation, the parent, interacting on a personal level to the younger generation, to the child? There are other things that I've seen quite a bit and that the literature talks about that can happen. Sometimes there's this like projective identification, or what parents are thinking about in terms of their own messaging that they've had with trauma. So for instance, they I've seen, like in therapy, for instance, where they have they have this idea that like all men are bad, or that the world is no good, and maybe you've seen this in your own work where, or that everyone's out for themselves, and so you've seen in your own work where a child may have a infant who's crying in their car seat or crying in their arms, and like, see that they're just trying to manipulate me with their cries. And that is this, then they're projecting their own feelings of the world onto that infant in the car seat. And so you may know that, of course, that infant isn't trying to manipulate them. They're just, they're trying to get their needs met. And over time, of course, if that parent continues to pass on that belief system, then not the infant, the parent continues to pass on the belief system, that infant is going to absorb that view of the world. That's one I really wanted to highlight. But of course, there are other means of transmission. There's social learning, there's family communication, and of course, there's biological, which could be like when the parent is pregnant, and there's cortisol levels, and also epigenetics, which is, of course, means that a lot of researchers are really excited about. So next slide. So how does intergenerational trauma affect babies? If we just look back at Katie, and if you just click one more time, we'll see when she was very, very young, she was very passive. Besides the way I showed her crying in her car seat, she ended up being, mom described her as a very passive baby. Because of all the way the trauma was happening, going on around her, she often would be very detached and just kind of be staring off into space. I think of that when you talk about that fight, flight, freeze, or fawn response. She often maybe was in like a freeze or fawn response because of everything that was going on around her. I talked about that language delay. She did have a language delay, and I'll talk about that in a second, and some mild motor delays as well, because she often didn't have room to explore her world, and some sleep and eating disturbances. And then as we look, as she gets a little bit older, and then she again continued with that language delay. So when I met her, like I said, she was saying like 1 or 2 word sentences. She would say like, me play, I go, and she was almost 4 years old, and had been away from the actual danger for about a year at that point. She was very fearful of men, had a lot of separation anxiety from mom, and was playing out a lot of those traumatic experiences. And then as we look just in general, what are some other those effects? When we go to the next slide, we see that in infants, I talked about that maybe freeze or fawn. So sometimes, babies can be maybe kind of like very quiet. And I actually don't have that up here, but you also can see very fussy, crying excessive babies that are crying very excessively. And I think of this kind of as being they're almost like when you have babies who are in these kind of experiences where the mother is they are having a lot of difficult time being able to care for the child in a way that would be typical, and they can't help them. Their arousal system is very high, and the parents' arousal system is very high, and they're having a hard time being able to calm the baby down. And so then their arousal, they're very dysregulated, and so that affects their appetite, which of course may affect their weight. They're very clingy or frightened. They're very difficult to soothe, and of course that affects sleep. So it affects affects all the things that we look for in babies, right? Sleep, eating, you know, all the things with infants. And then of course, all of those things, if they're struggling with those things, that it can of course affect their overall development. And which is, you know, are they walking on time? Are they crawling? Are they with their language? And then the very bottom, of course, that can affect how the attachment is going on with the parent. As we go on to the next slide, we see even more significant trauma signs, which could suggest, is there PTSD type symptoms in the child as well? So as the infant, the baby is getting a little older, are they able to feel like they have a secure base with the mother? Are they able to explore and play? What is their mood looking like? How are they reacting? Are they reacting to traumatic reminders? Like certainly Katie did, and she did have a lot of repetitive post-traumatic play, which in the end happened to be good, because then we could use that through therapy and help her heal through her experiences. You could also see persistent self-soothing behaviors, which can be harmful, like are they head banging, or you see some of these babies like picking out, you know, patches of hair, or, you know, picking other places on them, which can be, you know, concerning to parents. And of course, you know, more extreme aggression or maybe even sexualized behaviors. The next slide. So what are we doing about this then? Of course, I'm going quickly. I'm trying to make sure I get all this in on time. So the first thing is I find, you know, if you're in this world, and I'm sure you already know this, but it's hard to work with babies and, you know, very young children. You know, it's overwhelming with trauma. And so you really want to make sure, the quick plug for taking care of yourself, making sure you're checking in with yourself. And being reflective too about what's going on, because working with these sorts of families can really sometimes push some buttons in us, and sometimes it can come out of the blue, and also understanding that, you know, safety is very important for the families, emotional and physical safety, and also working with parents. So these are kind of the overviews I want to talk about. So going next. So when we think about babies, we have to make sure we're thinking about parents. Babies always come with another person. I oftentimes talk about moms, but of course it isn't always a mom. We know that. So when we're working with the infant, they're working with the baby, we have to take the parent into account. Next slide. And so oftentimes we know that in these situations, these kind of situations are going to affect the relationship between the baby and the parent. So that attachment, that relationship. And so we need to take a critical eye at that. That doesn't mean, you know, that's not a negative against the parent. You know, that parent's going through a hard time. So how can we strengthen that relationship? We know that helping reinforce that will be a source of resilience. It will be better all around for both the baby and for the parent. Next slide. Okay, so how do we help babies, or how do we help babies? We help the parents. And so first of all, we need to help the parents by figuring out, do they need any help? Do they need any help with what's going on with their trauma? Do they need a referral out for therapy? Maybe it's not therapy. Maybe they just need more supports in their own lives. I'm sure these are things you've already talked about in your previous presentations. And a lot of times it is about having more support in their life, more connections, more natural supports. You know, taking care of young children is very overwhelming, especially if you have trauma. So what are those natural supports? And the other thing is that we need to remember that when we parent, and this is for everybody really, but it evokes a lot of feelings from the past. And so especially when you've had a really troubling childhood or a lot of trauma in your, your childhood, it's going to bring up a lot of, negative feelings. I don't know if anyone here is a parent, probably at least some of us, but has anything ever come out of your mouth? You're like, oh my gosh, that was my mom, that was my dad, right? So I can't believe I just said that. I swore I'd never say that, or whatever. Or maybe it isn't even a bad thing, but you're just like, I swore I'd never say that. Well, the thing is that there's also going to be negative things that happen that are going to come out when we're parenting. And Selma Freiberg has this term called ghosts in the nursery. And when there are more ghosts in the nursery for these parents that are kind of hovering around and are affecting the way they're parenting their babies. One of the things I kind of think about is, the parent who it was in my office, and I've seen this actually more than once, but and there's a little, and they've been in a domestic violence relationship, and they had a little, boy toddler, and he raises up his little fist, and the parent says, "You're not going to do me like that. You're not going to hit me like that." And because what are they doing? They're like reacting as if, that little toddler is, the abuser. So there's all these like ghosts. And so what's really important for us to remember is that parents are doing the best they can. They're often reacting from the past as if the past is active in the present. And so we need to, ensure that we are not judging them as if in this kind of negative light, that we are meeting them where they're at and understanding that they're doing these things. I think that's just really important for us to do. That they're acting from this unconscious kind of material that's coming out. And so when we think about this kind of unconscious material on the next page, I think the other thing, the next slide, the other thing I think we need to do is also remember that we also have our own unconscious material that is acting on us as well, that we have our own biases, our own childhoods, our own things that we bring into the room, whatever. And so that are affecting the way we interact with families. And so I really like this quote from Carol Siegel, and it says, "Our histories decorate our past and present like familiar wallpaper. We do not notice it until we encounter someone else's unfamiliar wallpaper. The role of culture is inextricably linked with our thinking, feeling, acting, and reacting. In work with parents and children, we encounter behavior that does not feel right and makes us uncomfortable and critical. At that juncture, it is helpful to remember that we may be acting out of our own unconscious experience, and that our discomfort with parenting behavior does not mean that it is harmful or wrong." So I think that, no matter what room you're in, whether you're in the therapy room, the exam room, the daycare, room, or whatever room you're in with, children, babies, and parents, that we just are able to reflect when we feel uncomfortable, where is that uncomfortability coming from, and then act, from a more informed place. So on the next slide, here's the last one, and it's the longest, but so just click, Andrew, there we go. So we'll start here. So here are kind of goals and possible interventions, and I know you're from all sorts of disciplines, so take them for what they are, and this is not an exhaustive end all be all, but these are things I was kind of thinking about you might want to could potentially focus on. So increasing those feelings of emotional and physical safety. We know that a lot of times that's a point that's very, difficult for these families. We could, I'm sure, go on and on about how that shows up. So whether that's providing resources to help with physical safety, helping parents determine what is a realistic threat, when is my danger alarm just going off, when it doesn't need to go off, and when is it, truly a threat. Helping provide more emotional safety through providing, establishing routines and rituals for that baby. The next one. So I put this parent-child relationship here to help strengthen it, but actually a lot of the other things you would do are going to actually affect the parent-child relationship. Because like I already said, and you already know, a lot of times that's affected, it's weakened. So how can you increase attunement? Attunement will be increased by actually helping with development, which we'll touch on in a second, really helping avoid unnecessary separations as much as possible, advocating for avoiding unnecessary separations if these children are involved in child welfare, which a lot of them might be, these families might be. And we'll touch on this again. So the next one is affect regulation. So clearly we've talked about this a lot. So both the baby and the parent are struggling with probably arousal, they dysregulation. So, how can we help them with that? So I think really first the parent needs to be able to, better maintain regular levels of effective arousal. Can they trust their own body sensation? A lot of times parents can't. And they need to understand better that the baby they need to be co-regulated. A lot of times parents think that, oh, the baby should be able to stop crying or be able to go to sleep by themselves or whatever it is. So how can you help work that out, that co-regulation is key, and help with those sorts of things with that parent and baby. And so then with development, which is the next one, a lot of times parents have realistic expectations about development. And this, the more, and of course you don't say it in an expert way, well, this is what development looks like. But just saying, typically like, 6-month-olds do this, or, and I wonder if, I really like the I wonder, but, and then also explaining about adaptive coping, because, if you've been through trauma, a lot of things might be different because of the traumatic response. And so it might've changed things. So maybe they've been shot off the developmental tree because of trauma, and explaining that and how you can work together with them to get them back on, the right developmental track. And so then of course you need to assess and provide interventions as needed. And I'm sure you're all great at that. But I think really this developmental key will affect, I think, a lot of those other things as well, like affect regulation and parent-child relationship. And then the final one is really working on the trauma, focusing on that trauma and really normalizing that traumatic response, helping them understand, the parent understand what is normal. We've talked about distinguishing past from present. So when is the past coming into the room? When are they acting out of the past versus what's really happening in that present? It's that toddler in the present. It's normal for a toddler, who I said, who raised their fist. It's normal for a toddler to do that. It's okay not to want them to do it. It's normal for a baby in a car seat to cry out for their needs. They're not being manipulative. They're acting out of a past things. And the final, which is speak the unspeakable, is really about saying that it's the unspeakable is the trauma. We need to normalize speaking about trauma, and you need to be a safe person for them to be able to speak about those things. Okay, I hope I wasn't over, and I'm sorry I was rushed. So thank you.
Well, thank you. That was amazing, and really kind of highlighted some things that we haven't fully dug into yet in our series. So that was wonderful. We'll open it up for some questions at this point. And I'm happy to kick off with a question for you, Dr. Elhai. I'm also a psychologist, and I am always very interested, as a person who's not trained in parent-child interaction therapy or PCIT. We've seen some data come out that children with prenatal opioid exposure, prenatal substance exposure, that PCIT is a viable option for these families, and there is some evidence. But I'm always hesitant about the timeout procedures of PCIT and the time of, the attention piece. So often we hear we want to do time in and build connection for these kids. So I just wanted to hear your thoughts on that, because I know it's oftentimes a recommendation we hear for children in situations like Katie's.
Right. So PCIT is definitely an evidence-based treatment, and it's a wonderful treatment. As Dr. Rowley, I'm sure knows, I am more of the very attachment-based, like I do child-parent psychotherapy. I'm definitely more of a time in type of person. I used to do PCIT quite a bit until I moved to Ohio and learned CPP. And now I don't do PCIT anymore. So I'm not speaking against PCIT. I want to be really, really clear. I just have changed what I do. So I would probably advocate. I think it depends on the family and what works for the family and how the family, some families I think like lean more toward needing that structure, but I think kids with a lot of trauma who don't like separations tend to need more time in type things because they have uh, separations are triggering, I guess is what I would say.
It's helpful to hear that from you, because that's kind of where I was drawing from. And I was like, in real life practice, like I can't even separate some of my patients just to observe their behavior away from their parent. And so that's what's really challenging. So I can't imagine in the context of, okay, now we have to address this in a timeout way, trying to get them separated. So thank you for that.
Mm-hmm.
Andrea, did you have a question?
Yeah, I did. And I think it's kind of a nice entree into my question, because I think that's probably why it's so important when folks come into our clinics or wherever to ask about trauma history. And so I'm wondering for our group, and I know our clinics, we've really worked on that over the years, but I'm wondering about your advice of how do we normalize asking about trauma? How do our folks that are just in their clinics and have never maybe had training in trauma-informed care specifically, or maybe had a lecture on it, how do they actually work that into their practice? And what do you recommend?
So I think it would be good to have some sort of training. I think you have to get really comfortable. Like, I think like practice with colleagues, practice with your family, just using the words, asking the questions. I mean, I remember way back when, just getting used to saying words like penis and vagina. Sorry, everyone. But just saying things because it is uncomfortable. I mean, it is uncomfortable to ask things. And I think the more you just say, has your child ever had any trauma? Has they ever been, hit? Have they ever, I think just the more, but I think it takes a lot of practice because like speaking the unspeakable is really important. But I also want to say that sometimes the things you ask the very first time you meet someone is the answers you get is not the same, the answers you get later. So it's okay not to ask everything right away, or to ask, but to know that you will need to ask later as you have a better relationship with them. So
I also loved what you were talking about when you said like we parent how we were parented, and we catch ourselves saying what we heard. And I think that's sometimes how I start the conversation myself with patients, families, is talk to me about how you were parented. Mm-hmm. And then I'm able to kind of follow their lead with what they're able to share off the top of the conversation. But just like that, what you were saying, Dr. Elhai, get comfortable with it. Was there ever anyone in your family that hit each other or used inappropriate words with each other, that kind of thing? So I think that's so important in terms of working with these kids.
Mm-hmm.
Yeah, my experience is that often that I'm more uncomfortable with that than the parent or client because that's been a real part of their experience. For me, it's not been. And so even though I have a penis, I had to learn to be comfortable with saying that word. And it's similarly about asking about traumatic experiences. But I really liked Dr. Elhai or Adrian, which is easier for me to say, that your use of the word wonder, because I think when we go in with a sense, both an attitude and language that's about, I wonder what that was like for you. I wonder what it was like when you were a child. It's a lot different than saying, were you abused and did your father rape you or whatever? So when you come in with that wonder, that it tends to get under defenses because you're not the expert. You're not saying something that could be perceived as critical. And my experience is that a lot of times, as you were saying about Katie's mom, there's a sense that I am really bad, that I shouldn't have these babies. And so that defensiveness can get in the way of the healing and the connection that you talk so eloquently about. So that wasn't a question, but
no,
that's a thought.
a good point. Yeah.
Well, I just want to comment that I always have this feeling when we're done with this kind of talk, there's so many great ideas. People are aware of so many resources. And then I'm starting kind of trying to put myself in the position of this mother. And if somebody told me all those things about my child and what we could do, I would feel pretty overwhelmed. So Michelle, it's your task to figure out how much food she can take in at a
Yeah.
time in terms of what needs to happen and where's the priority, because we've just pretty much planned out the rest of her life for the next 4 or 5 years, I think.
Mhm.
So just taking into consideration, what does mom want? What is she capable of doing? And what seems reasonable to her? That partnership. I just wanted to reemphasize that.
Yes, that's a great summary. Yes, small and manageable tasks. You got it, Alicia, in the chat box, and really good summary, John, of how we have to only provide, and meet mom where she is too. So, Michelle, did you have anything you wanted to add?
I was just going to say that's very important. It's a very important part of my job. So, absolutely.
Steph also had pointed out how important it is to go back to basic needs, because if those aren't addressed, then it's going to be hard to work with anything else.
Absolutely.
Definitely. Well, what a lovely conversation today. We had a great speaker, great case, lots of great ideas that have come from it. Thank you all for participating. We will see you in 2 weeks where we get to hear from Dr. Raleigh Roberts again as our didactic presenter. But please, again, take me up on my pitch to present a case. It's very easy. I'm sorry, I shouldn't say case. I should say challenge or opportunity. And so all you have to do is complete a quick form, and Jesse will get all of your information onto the slides for you. We can present the slides if you choose, but yes, you get free suggestions and free swag. And so definitely please take us up on that. We only have, I want to say 3 sessions left, because our last session we're going to do a little differently and just have a conversation around models of care. So we won't have a case that week. So we have sessions 7, 8, and 9 left to present a case. So we really invite you. It's so rich when we get cases from your direct work. So otherwise, we will end a few minutes early. So thank you all and have a great weekend.